Hi guys, welcome to video 2 of our review of cases 5 and 7 for the physiology. So I'm just going to cover the physiology relevant activities here. The first activity that was really relevant to me, first of all, Dr. Algul had you guys draw out the hormones over the female reproductive cycle. You should know that, of course. Good idea to know how those hormones go up and down over the course of the cycle. I'm not going to review it here, but of course I'll show you a picture of it in a moment. So a good idea for you to know that. This was the part of the activity that I really wrote. We were talking about anovulatory bleeding and what hormone might be missing. So I asked you guys to fill out this table addressing the role of estrogen and progesterone in the process of endometrial proliferation and stabilization, during the menstrual cycle. So estrogen, basically, these two things kind of do different things. Estrogen is going to increase the proliferation of the endometrium, increase contractility, and your cervical glands are going to be more watery. So basically, this is all oriented toward getting your sperm to the egg. Okay, so all of these things will help propel the sperm or help get the sperm to the egg, and you're also preparing the endometrium for implantation. Nice, big, proliferated endometrium ready to go for implantation to take place. The progesterone, on the other hand, stabilizes the endometrium, decreases the contractility, and your cervical glands the secretions become more viscous. So this forms, more of a plug in the cervix. So all of this is really meant to nurture an implanted embryo. So you decrease the contractility to keep it where it is. You stabilize the endometrium so that you don't basically proliferate to the point where you just wash away and you bleed, and the implanted embryo goes along with it. And you have this plug here that's meant to keep everything protect the area, right? These two things do different things. They both have their role. Progesterone would be the one that would be lacking because you get the proliferation of the endometrium without the stabilization. And so what happens is you proliferate and don't stabilize, and you end up bleeding abnormally, okay, for the anovulatory bleeding. And you would lack progesterone because you're anovulatory, which means you're not luteinizing, which means you don't have your progesterone, okay? All right. You want to test to see if she's menopausal, so I asked you to fill out this diagram. And basically, this is just the hypothalamus, pituitary, gonadal axis. So this is your hypothalamus, this is your pituitary, this is your gonad. And this is GnRH, this is LH and FSH, and these stimulate the ovary to produce inhibin, which feeds back on the anterior pituitary, and produce estrogen, which feeds back both on the anterior pituitary and the hypothalamus. So what would you expect if she's menopausal? If she's menopausal, then your estrogen is down. So you don't have the negative feedback on the hypothalamus and the anterior pituitary. The FSH goes high. And so you can see that here. You might remember this figure from my lesson. This is your gonadotropins over the course of a lifetime. So you're cycling and they're going up and down with your cycles here. And you hit menopause and the FSH goes up and it stays super high, and that's because there's not as much estrogen, and so that negative feedback isn't there anymore to keep the FSH and the LH down. Okay, so you test a woman to see if she's in menopause. You look for this FSH, and if it's really high, that tells you, and that'll be a theme here. If you have a premenarche and they have trauma such that there's damage to the pituitary that prevents inhibition of secretion, then that means that your estrogen is no longer inhibiting secretion of LH and FSH, okay? So as a result of that, your FSH will be high and your LH will be high, and that will cause you to release more estrogen. So your estrogen will be high and your inhibin will be released more, that'll be high. And the GnRH will be low, because you're still getting feedback of estrogen on the hypothalamus, and that's reducing the GnRH secretion, okay? So this is what you'd expect to see based upon that axis that I just showed you, okay? And another possibility, a rare genetic condition which causes precocious puberty, that is, your estrogen goes up at a very early age. First, fill in the blanks in the concept map. Second of all, explain why this condition could cause precocious puberty. So I guess I don't have the answer here, but what you have here is you have progesterone here and here being produced in response to LH. The androstenedione becomes testosterone here in your thecal cell, and so your progesterone is feeding back and forth. Your androstenedione, your androgen goes back into the granulosa cell, and you get conversion to testosterone here, and eventually estrogen from that. And of course, this is where your aromatase is in the granulosa cell here. And so what's happening is you have excess aromatase, you produce excess estrogen, and that'll cause a precocious puberty. Puberty. Okay. I did just want to remind you that there is an interaction here with the male as well. You have FSH stimulating the Sertoli cell here, and what the Sertoli cell here does here in the production of testosterone is basically it's producing growth factors and other products which sort of feed into the production of testosterone. So your Leydig cells produce the testosterone in the male, but the Sertoli cell has its role here in terms of the production, in that it does produce growth factors and other things, which will potentiate this synthesis. So here's your synthetic pathway here, where your cholesterol is being converted to testosterone. The testosterone is released into the bloodstream here. And of course, it also binds to androgen binding protein, and it ends up in the lumen here and facilitates the development of your sperm, which are associated with your Sertoli cells here. Okay, so there's your testosterone in the bloodstream. It binds the ABP, and here's how it feeds into the lumen here and helps develop these sperm here, or contributes to the development. All right, you do produce estradiol here from the testosterone through the aromatase, and that will increase your protein synthesis as well. So there is sort of a feedback back and forth. The Leydig cell does produce the testosterone, but there is some feedback back and forth between the two. Okay, and there are your enzymes, and there's your conversion. So we move on to the infertility case. So you're investigating why the menstrual cycles might be irregular. So you're looking to see if Kelsey has a proper ovarian reserve. Another way of saying that is, does she have enough follicles that are functioning correctly? So the first thing you do, and everybody does this, is you look at FSH early in the cycle. So if you're menstruating here, at about day 3 in the cycle, which would be somewhere in here on this scale where ovulation is day 0, you take a look at the FSH levels and you see if they're extraordinarily high. If they're extraordinarily high, if they're much higher than normal, then that means that you aren't producing enough estradiol, because estradiol is feeding back negatively upon the hypothalamus and the pituitary, and it should be keeping this FSH at a moderate level. And if it's not doing that, if the FSH is high, then that's a sign that you don't have enough follicles producing enough estrogen. Okay. Another thing that they do, insurance companies like to see you do this, that's my understanding, because if the patient fails the test, that's one reason for them not to pay. I'll get to that in a moment. So this is, you administer clomiphene, which is a drug that blocks the negative feedback of estrogen upon the hypothalamus. You do that at about day 5, and then you look at the FSH levels at about day 10. So when you inject this into the female, you inhibit the estrogen receptors in the hypothalamus, and that causes your FSH to go up. Okay, more FSH means more estrogen production. So if you're a normal female and you've developed your granulosa, remember they're proliferating during this phase and you have enough potential to produce enough estrogen, you should produce enough estrogen to overcome the effect of the drug so that the negative feedback comes back on the hypothalamus and the FSH levels drop back down toward normal. If that does not happen, then it's an indication, and the FSH levels remain high because of the clomiphene, then that's an indication that you might not have enough follicles being recruited, and therefore you don't have enough potential to make estrogen, and therefore the estrogen levels can't overcome the effect of the drug, and your FSH remains high rather than returning back toward a normal level. Okay? So the OB-GYN people don't like to do this. And as a matter of fact, the American Association of Gynecologists or something like that actually recommends against it. The reason but insurance companies will try to insist that you do it. This is my understanding. And the reason is because if the woman can't pass this test and get the FSH back down toward normal, then it's an indication that there aren't enough follicles being recruited, and it gives the insurance companies a reason not to pay out for fertility drugs. So it is a test that you'll see in textbooks, you'll see it on the internet. It is not recommended, is my understanding, by the gynecologists, but the insurance companies like to see you do it. So that's a war that you may encounter at some point in your career should you go into that area. In any case, this is how the test works. It's an interesting physiological problem, if nothing else. Okay? Okay. So if her ovarian reserve is down, then the FSH will be high early in the cycle, and even if the FSH is normal, if you give this clomiphene, you may find out that the patient can't produce enough estrogen to get that FSH back down toward normal. You'll see a high FSH around day 10 if you inject on day 5, and that is an indication that there may be a low ovarian reserve as well, and that could be a cause for the infertility. Okay? So I had this concept map for sperm morphology on the male side, and how basically this concept map covers erection on the right here, and it covers capacitation on the left. So as far as erection is concerned, the increase in parasympathetic tone that you get if you're a male leads to an increase in NO and an increase in cyclic GMP, and that relaxes the smooth muscle, and you get vasodilation and increased blood flow to the penis. So for those of you who just couldn't wait to see me review this from the vital fluids block, this is how it works. We actually covered this Now in the vital fluids block, we told you that vascular smooth muscle is innervated by sympathetic only. So that is true with a few exceptions, as I said then, and one of those exceptions is the male genitalia. So ordinarily, the ACH that you see here binds to an M3 receptor on the endothelial cell. Usually this ACH comes from sympathetic cholinergic activation, and what that means is you have sympathetic fibers in the area that release ACH rather than norepinephrine. Okay? In any case, in the male, this ACH comes from the parasympathetic nervous system. You bind your muscarinic receptor, you activate phospholipase C, which generates IP3. That increases calcium. Calcium binds calmodulin, and you get activation of nitric oxide synthase. You produce nitric oxide, which is a gas, so it's membrane permeant. It goes from the endothelial cell to the smooth muscle cell. That activates guanylyl cyclase, and you produce cyclic GMP in the smooth muscle cell, and you increase the cyclic GMP. That causes vasodilation through a number of different mechanisms. And the first one indicated here, you increase myosin light chain phosphatase activity. That cleaves off phosphate from myosin light chain, and you get relaxation. Remember, contraction of smooth muscle takes place when myosin light chain is phosphorylated. So you cleave that phosphate off and you get relaxation, the opposite. You can also activate protein kinase G. This will cause phospholamban phosphorylation. You'll get more calcium uptake into the ER. That'll drop cytosolic calcium. That will lead to less activation of myosin light chain kinase, more myosin light chain, less phosphorylated myosin light chain, and relaxation. And you get some decrease in the membrane voltage because you get an activation of a potassium channel, and that will decrease cytosolic calcium as well. Okay. Basically, as far as this exercise is concerned, increased cyclic GMP causes relaxation of smooth muscle. You get vasodilation, and you get more blood flow to the area, engorgement of the penis with blood, and an erection. So this is relevant because Viagra works on a phosphodiesterase, which usually eliminates cyclic GMP and turns it into GMP. So what Viagra does is it inhibits the phosphodiesterase, which means you have more cyclic GMP and you get more relaxation of the smooth muscle. So it facilitates relaxation of the smooth muscle and erection, and that's how it works. Okay. All right, so back to our concept map. Come on, there we go. Then we sort of enter the capacitation phase of this concept map. You have fluid containing zinc and other factors being added from the bulbourethral gland into, my understanding is that there's a section of the ureter that's actually added to, not the vas deferens. Dr. Wilson corrected me when he saw me do this in front of the class when the activities were going on. That would be very important to an anatomist. I just want you to know it's added somewhere before exit, okay? And so you have these added to the vas deferens. So in truth, the process of alkalinization of the sperm cytosol really begins at this point, and so does the process of increasing calcium stores. Your fertilization promoting peptide is added here. That increases cyclic AMP. That probably starts the process of increasing calcium stores. So you guys could have legitimately put both of those somewhere in this area. I did not choose to do that. But really that process starts here, and then it intensifies as you go through this process of capacitation. So you get ejaculation, the sperm enters the vagina, and the zinc is washed away. So you can think of the zinc literally sitting in the channel mouth of the voltage-dependent proton channels. And so The zinc is washed away in the vagina, and as all these fluids become dilute, as you go from the vagina into the oviduct and you approach the egg, and so the alkalinization, which actually did start here, when you wash the zinc away, the alkalinization becomes intensified, and you get even more of it. And you also get a further increase in calcium stores here. The alkalinization is increasing the activity of cat spur, which is allowing more calcium to come in. That also starts here, and that, becomes intensified, and so you get even more increase in calcium stores. You get even more increase in CICR, which is also sort of starting here. And so all this intensifies. And so your sperm become a little bit motile when this fluid is added. But when you start to wash away those fluids, they become even more motile, as though you get even more alkalinization, you get even more calcium entry, you get more increase in calcium stores, and you get even more CICR. Until, as you approach the egg, you enter a hypermotile phase, where all the sperm that get that far become hypermotile and zoom in on the target, and the acrosomal reaction takes place. The sperm starts to break down the barriers surrounding the egg, and you get fertilization and the magic of new life. Okay, so that's how this process of capacitation sort of operates. It really starts here and just becomes more and more intense as you get farther and farther in through the female reproductive tract until you're approaching the egg and you're in this hypermotility phase, okay? So bear that in mind. This really isn't a step-by-step process so much as it is just a process that becomes more and more intense as it goes on, and as you wash the zinc away and as your alkalinization takes place. A very common question that I got was, how does the alkalinization increase the motility? It does a couple things. First of all, it increases the activity of that cat spur channel. The other thing that you might want to bear in mind is that protons compete with calcium at calcium binding sites in the cytosol, and that means it's competing with calcium binding sites on your contractile proteins. And so as you alkalize the cytosol, the protons are going away, and it allows for more calcium binding to take place. That increases the motility. So you're getting more calcium entry, and you're also getting more calcium binding. And so that's why this alkalization really helps. Okay? All right. That's all I've got for this video. Thank you for your attention, and I'll see you guys in the rooms later on.